to physical setup. Now we're going to talk about some ways to physically set up when you're going to put the eStim unit on a person. We're going to have to think about first electrode size. What did we say about electrode size? Well, we said smaller electrodes are really good for pinpointing specific muscles, but the smaller the electrode, the more painful the electrode, and you don't want, especially initially, a painful experience. So we're going to have to strike a balance from electrode size from that which is most comfortable, yet will give us the effect that we want. Cleaning the site, it's a good idea to make sure that the site that the electrode is going to go on is clean and not going to have any other, remember we don't want anything slowing the flow of that electricity down. We're going to make sure our site prep is clean. It doesn't necessarily have to be alcohol, it just needs to be clean. I wouldn't necessarily suggest alcohol just in case someone was sensitive to that. But anyway, it makes sense that the area is clean, and we want a good surface for the electrode to stick to. Electrode placement we talked about. Electrode placement matters that the electrodes are placed in line with the longitudinal direction of the muscle fibers, and it also matters how close or far they are apart. So we'll have to make some decisions about that whenever we're setting this up. Now, used to securing electrodes was harder. Back whenever I used to do this, we had a gel that you had to put on the electrodes. You had to put the electrodes on the patient, figure out how to secure them to the patient. That's not a big deal now because electrodes now come pre-gelled, pre-sticky. So pretty much you just stick them down and they stay right where they ought to stay. So that's not a big consideration for us. Some other things to consider. Has this person been cleared for active range of motion? Because if they haven't, they can't have eStim, because remember, we are actually stimulating the muscle, and the muscle is going to make the joint move. So we have active range of motion going on here. So if a person hasn't been cleared for active range of motion or been okay for that, no eStim should take place. Do they have sensory deficits to the point where they can't even warn you if something's too uncomfortable or if something's unbearable? It may not be the most effective for patients with sensory deficits. Do they have metal implants? Because metal is a great conductor of electricity. And if they have a metal implant where you're sending that electricity is going to heat that metal up, and that's not going to be good. So you're going to want to do a little background check for metal implants. And I've talked about this several times. Is the person cognitively aware enough and able to be alert and oriented and working with you and working with the machine and working with the overall goal of the program that you have set up for them? So those are all considerations of things that you have to think about. And yet there's more. Do you have service competency for this? Do you feel service competent for operating the eStim machine? You know, we've had this in school. You're going to get a feel for it. But once you get out there and start practicing, where your license is on the line, you need to make sure that you go back and review your notes and look at this lecture. You can download this MP4 and keep it forever so that you can play it forever if you want to review this lecture. And I would suggest that you do that. Download it and keep it. Review your notes about this. Go over electrode size, electrode current, go over the parameters. And if the next one is not true, you're dead in the tracks. If your OT doesn't have the credentials or the experience with FES, then you using it is not even an option. Because if you can't get what you need to get out of the FES unit, and you can't go to your OT and say, hey, I'm not getting what I need here, what do you suggest I do to make this contraction better or to make this program more effective? And they're like, well, I don't know anything about that. That's not the supervision that you need. You should not be performing FES on someone if you have an OT supervisor who doesn't know anything about or doesn't have any education behind their belt about FES. And this is a great question to ask yourself. You know that FES is preparatory. So what am I preparing this patient for? Am I doing this so that we can get active elbow extension, so that we can get weight bearing, so that we can get more functional use of an upper extremity that's been affected by a stroke? What is it? What is it that I'm preparing for? Am I doing this for proximal stability? Am I doing this for shoulder subluxation, for proximal stability for that arm, so that I might have more distal mobility in the future for assisting with ADLs, any type of other occupation-based task? And is there a functional or purposeful task that I can incorporate here while I'm actually using the FES unit? Which is one of the reasons that the BioNS is The BioNS unit that you learned about is so popular because it's poised for function. It's poised to alternate finger flexion and wrist and finger extension for grasp release activities. So the more function that you can put into your task, the more benefit your FES is going to have, because you're going to incorporate active movement of the patient that's going to be working with active movement of the stim unit, and we said that was the most powerful combination. And when you put that with something that has meaning, you've got a triple play there. You've got triple benefit. Okay, so a final thing about electrodes. Patients can have adverse short-term reactions to electrodes, which means that underneath site, right underneath the electrode, can get really red. You can help to prevent that by cleaning the site with just soap and water and no other kind of irritating agent. You can make sure that you get full surface contact with the skin, so you don't want an electrode gel that's not, like if you've got an old electrode that's not really sticking very well, get rid of that. They're cheap. You can replace those with new electrodes. So you want that good surface-to-surface contact with the skin. It is sticky, and you don't want to forcibly remove the electrode, because it could be like removing a really sticky Band-Aid that could like rip the hair and do little micro tears in the skin, and you don't want that. So ease those off gently. Avoid using really high concentrated currents under the electrodes. The higher you turn the intensity or the dial on the electrode, the more current you're putting to that skin. So if you can figure out other ways to get your effect as beneficial, or to get the type and the amount of range of motion that you need with less current, that's going to be your goal. And there are ways to do that, and we'll look at those. We are going to be using the EMS TS1311 electric muscle stimulator. It looks like this. It has a little closed off section on the front that you can flip open. When you flip it open, you can see all digital readouts up here. So you've got some abbreviations here. You got channel 1, channel 2. We've got a mode that we can change by this button. We've got our battery indicator here. We've got our rate. We'll talk more about rate here in a minute. You've got some simple directions here. You've got the dials up here on top. Okay, this would be the dial, the intensity dial for channel 1. This is the intensity dial for channel 2. And you've got these little bars that go up the side here. When these guys here are moving, blip, 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 that means you've actually got electric current going through the electrode here, passing down through the electrode sites. So you've got your wire here that's going to lead to your electrode sites. When this black bar is going up and up and up, that means the electricity is actually flowing. When there's no activity right here and there's no bar, the bar is silent, that means that the unit is either off, or it's on rest mode, or it's between cycles. And we'll talk about cycles in a minute. But the main thing to know is to keep your eye on this black bar right here, because if this is going up, then you've got some sensation and some signal going out to your electrodes, and you'll all get to do this on each other. So for the mode, you've got 3 choices of mode, and we talked about mode being able to be changed right here. There's 3 choices for electrode mode. There's alternate, so it would run channel 1 and then channel 2. So what alternate would mean would be is if you had a wire hooked in here and another set of wires hooked in here, and you had both channel 1 and channel 2 on, and you had the mode as alternate, it would mean that maybe you would want channel 1 to fire the finger flexors for grasp for, let's say, 10 seconds. And then after that 10 seconds was over, channel 1 shuts off, channel 2 turns on, and alternately fires finger extensors for release. So that would be alternate. So you'd have 2 cables, you'd have 2 channels running out. You'd have a cable running out to electrodes that were on the anterior forearm, and you'd have a cable running here to electrodes that were on the posterior forearm. Of course, the anterior forearm cables here would be stimulating finger flexion, and then when that channel shut off, you'd have your posterior forearm electrodes stimulating finger and wrist extension. So that would be an alternating mode. Synchronous mode runs channel 1 and channel 2 simultaneously. So let's say that you had 2 electrodes, two sets of wires in, You have channel 1 wire. So you have it, let's say we want to work on extending the elbow and dropping a, let's say a block into a bucket. So you'd have channel 1 going to the triceps, which would extend the elbow. You'd have channel 2 hooked up to the wrist and finger extensors to drop the object as you needed it to. And you're going to have those on what mode? They're going to be on synchronous. So both are going to come on at the same time. Channel 1's going to come on and channel 2 at the same time. So what we're going to get is we're going to get nice elbow extension combined with wrist and finger extension. So we'll have our stretch out and our drop at the same time. Or you can have another mode. You can have a constant mode that runs both channels constantly. And it will say here on the mode, it will say constant right here. And the constant mode is usually used when you're in the testing situation and you're trying to figure out where to put the electrode, and you don't want the machine cycling, like resting and stopping, resting, starting and stopping, starting and stopping. If you don't want that, you can keep it on constant mode and keep this will be going constantly then. This little black bar will be going up constantly, showing you that you have constant output. So again, the 3 mode choices will be, I think, crystal clear to you once you actually put this on yourself and go through the 3 choices. Okay, ramp time. Ramp time is important because for a couple of reasons. Ramp time is what keeps the E-stim unit from like firing all at 1 second. What you don't want, and would not be a normal response. Let's say if you were stimulating someone's release, if you're stimulating the wrist, the finger extensors. Well, normally when you go to grab something, your finger extensors don't just fly open. They gradually open. And our ramp time is going to let us build in that gradual movement. So let's say we have a ramp time, which again is settable on the unit. You have a ramp time of 6 seconds. And we're working on stimulating our finger extensors. So what the person's going to feel is they're going to feel that tingle, and they're going to feel a slow ramp up for 6 seconds. And then after 6 seconds, they're going to feel the full impact of your intensity for the next 10 seconds. So our total on time was 16 seconds total, okay? And that's going to matter because you're going to have to set that total on time. Okay? But your ramp time doesn't count in the total on time because it's not at its full peak experience. The full peak experience here is 10 seconds. So really, we've got the full effect of our E-stim unit happening 10 seconds here. The 6 second ramp time is letting us get that nice gradual pull up into wrist and finger extension. Okay, I hope that makes sense to you. The other reason it needs to make sense to you is that because you only need to figure in the total peak time when you're figuring out how long you want your patient to rest. Because rest time is critical, because remember we said we could over fatigue somebody. So if we want someone to rest, we want them to rest 3 times as long as our peak on time. So in this case, we would have a peak on time of 10 seconds. So our rest time would be a built-in rest time of 30 seconds. So let's say we would have our total on time set for 16 seconds. 6 seconds of that would be our ramp, that we get ramped up to full speed. 10 seconds of that at full intensity, and then we're going to rest out 30 seconds more, and then we're going to cycle over again just like this. 6 seconds of ramp up, 10 seconds of full on time, and then we're going to rest again 30 seconds. And that's how the E-stim unit will be set for on time and off time, and that's called a duty cycle. A duty cycle of on time and off time. So total off time, or total rest time, think about it as rest time, should be 3 times the peak on time. So in this case we said 6 second ramp, 10 second peak. Our rest time would then be 30 seconds. And you can set those at whatever. This is totally up to you. This ramp time, on time, total on time, this is totally set up by you for whatever activity, for whatever peak on time fits the activity that you have going on at that moment. You can have it for less. You can have it for 8 seconds. Just know that this is going to be up to you. It's a parameter you can set between you and your OT. Pulse rate is equally important. The best way I can explain this to you is that pulse rates or pulses per second or bursts, burst of energy or burst of electricity per second. If you have low pulse rates, you can have jumpy contractions, which would be like instead of right under your electrode, instead of feeling a really smooth contraction, you would feel a kind of like bumpy, like bump 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 contraction. Okay. The good thing about low pulse rates is the lower the pulse rate, the less fatigue you have. So you want to get by with as little pulse rate as you can get by with, but you also don't want to have that jerky contraction. You want a smooth contraction, so you want to make sure that your pulse rate is low enough to prevent fatigue, but high enough to get a smooth contraction. And usually that's between 30 and 50 pulses per second. But one thing I want you guys to do with your eStim units is to play around with this pulse time and make sure that you're seeing the difference between that. I want you to feel that jumpy low pulse contraction so that you can feel the difference between that and that nice smooth contraction that you should be able to get by changing your pulse rate. Again, pulse rates start at, I believe on the units, 40 hertz or 40 pulses per second and go up from there. I'm not sure if you can go much lower. I could be wrong about that, but that's totally settable on the machine. It's back on the machine at the rate. Okay, this rate here, that's the hertz, 40 hertz, that's 40 pulses per second, and you can go up and down from there. Pulse width is a little bit different concept. It's measured in microseconds. It's adjustable from 50 to 300. The range for strengthening is between 100 and 600. This is not something I suggest that you change a lot. I would suggest starting at 120 microseconds and not varying that too much. You can increase the current dosage two ways. One is by the amplitude or the dial on the top, and one is by pulse width, which is what we're talking about here. So again, I would not recommend too much change within pulse width. Try to set that at a good 120, 150 and stick with that. And during lab, I'll give you a chance to play with that as well, and get a feel for, sorry about that, and get a feel for the differences between, let me get this sized, between pulse width and pulse rate. Okay, no, I want you to get a feel for the difference between lower and higher pulse widths. So for getting started, okay, this is what we're going to do in lab before we get started. The intensity of the dose of the current that you're sending to your partner is in milliamps, measured in milliamps. And again, you start that right here. There's a click dial on the top. It clicks to start, and then you can see there's increments on the top of this that'll show you how many milliamps of currents that you are dosing out at any one time. And again, this is our active output bar right here. So if this black bar is moving, then you definitely are sending current. Okay. Asymmetrical and symmetrical waveforms, I think we can change these on our units. The best way to think about these, and the most, probably a simplified way, but it's the best way to explain it, is that there's something called an asymmetrical waveform and a symmetrical waveform. A symmetrical waveform is if you could think of this being your red wire and this being your white wire, or this being one electrode and this being another electrode. When in an asymmetrical form, one of your electrodes is 80% strength and with the other is 20% strength. So in asymmetrical waveform, one of your electrodes is going to be more active than the other, just by virtue of the waveform. In symmetrical waveform, you're looking at a 50-50 situation. Your electrodes are the same, they have the same output going from one to the other. Benefits are, okay, think about this. For an asymmetrical waveform, if you want one electrode to be a little bit more stout or to have a little bit more oomph to get a little bit better contraction, you can change to asymmetrical and make that electrode a little bit more powerful. We said you could also do that by trimming the electrode down, right? But if you don't want to trim your electrode down, if you want to leave it its regular size, and you want to make it a little bit more powerful, you can flip to an asymmetrical waveform. Sometimes asymmetrical waveforms are not comfortable, which is why symmetrical waveforms are an option. So if you've got someone that's very sensitive, that can't take very much stimulation, you might want to flip to a symmetrical waveform because it's going to be more comfortable and that both of those electrodes are going to be equal in power. So you might want to go back and just watch this slide again. Just rewind what I just said so you can hear me say it over again, because it's important for you to be able to get the benefit that you want out of the machine, to understand how to make that one electrode a little more powerful if you need it.